Öncelikle ROMER Talks'a Abdulhamit, sen de katkı verdiğin için çok teşekkürler. Tüm katılımcılara da hoş geldin diyoruz ROMER adına. Abdülhamit'le biz 2014 yılında tanıştık. Öncesinde Uludağ Üniversitesi Makine Mühendisliği bölümünü birincilikle bitirerek bizim bölümümüze geldi. Geldiğinde de 3 yıl hem asistanlığımızı yaptı hem de master'ını bizimle tamamladıktan sonra Imperial College'a İngiltere'ye doktora için gitti. Doktora sonrasında da postdoc olarak doktorasını tamamladıktan sonra 2020 Ocağı gibi demiştik galiba, değil mi? Harvard'da şu an postdoc olarak görevine çalışmalarına devam ediyor. Bitirdiğinde de inşallah tekrar ODTÜ'de görüşmeyi arzu ediyoruz. Bugünkü konuşması Continuum Robots for Minimally Invasive Surgery üzerine olacak. Abdülhamit, top sende.
Teşekkür ederim hocam. Sağ olun bu davetiniz için de. Ben de bahsettiğiniz gibi ODTÜ'de tamamlamıştım yüksek lisansımı. İngilizce yapacağım. Birkaç sefer İngilizce bazı kısımlarını yapmıştım. O yüzden biraz daha rahat hissediyorum kendimi. Şöyle devam edebilirim. So now, today, I will present how Continuum Robots are shaping minimally invasive robotic surgery and what are the key technologies to introduce autonomy to these devices with some examples from my PhD and postdoc research. So minimally invasive surgery has been very popular recently due to its significant benefits compared to conventional surgical techniques with shorter recovery times, reduced trauma, and shorter hospital stays. And it could be conducted manually or using robotics, as seen in these laparoscopy examples. Here in this manual example, the medical instruments are inserted into the abdomen of the patient through small holes. However, clinicians mostly need to stand in uncomfortable postures during long operations. This could cause physical and mental stress, neck and back pain, and numbness in their wrists. Also, using these instruments is often very unintuitive to control. For example, here in laparoscopic surgery, the surgeon has to move their hand right to move the tip of the instrument left, and up hand movement corresponds to down tip movement. These mental remappings unfortunately increase the cognitive burden of the procedure. To solve these problems, research into integrating robotics for such procedures and using better input devices has been the hottest topic studied by many research groups and surgical robotics companies for the last several decades. Here we see one of the robots from the Da Vinci family, which is one of the most popular surgical robots on the market. As you see, the surgeon is sitting in an ergonomic control unit with joysticks and foot pedals to control the motions of the robot arm and the endoscope. One of the most promising tools in minimally invasive robotic surgery is Continuum Robots. These are long, flexible instruments, and they could be inserted into natural orifices of the body, or they could be inserted through the skin and could navigate through, for example, the vessels. These procedures are called endoluminal procedures. Continuum flexible robots could also be used to navigate through soft tissues, as in this neurosurgery example, where a straight path is not preferable due to some anatomical constraints, and a curvilinear path is wanted to be followed. And here the problem is a little bit different compared to these procedures where the catheter tip may move sideways as it is in the cavity. However, here, since it is surrounded by tissue, it needs to go forward to be able to steer just like a car or a fixed-wing plane in 3D. In addition to integrating robotics into these systems, introducing autonomy is also getting more and more popular. The key requirements to introduce autonomy to these robots to navigate inside the body are effective real-time tip tracking or shape sensing, modeling, and control. For tracking and sensing, there are many medical imaging and proprioceptive sensing methods that could be used depending on the procedure. I'll touch on some of them during my presentation. Throughout my PhD and postdoc research, I have had the opportunity to develop methods that cover all these key requirements for both endoluminal and exoluminal continuum robots. I will now start with my PhD project covering steerable needle, shape sensing and control. Then I will continue with my postdoc research, where I will present our methods to model tendon-actuated telescoping robots used for heart valve repair. This is the EDEN 2020 project, which I was a part of during my PhD. This project aimed one-stop diagnosis and minimally invasive treatment in neurosurgery, and it was led by my PhD supervisor at Imperial, Professor Ferdinando Rodriguez y Baena. In this operating room illustration, we see the project's components. Here, in this procedure, which is a kind of keyhole brain surgery, the aim is to be able to access a certain location in the brain by inserting the needle into the patient's brain through a small hole on the skull and by avoiding anatomical obstacles, similar to the illustration I showed you in the previous slide. The reason for this could be to be able to take a biopsy tissue or to deliver chemotherapy drugs to a brain tumor. Therefore, a steerable needle was developed, and to make it intuitive to use for the surgeon, it was integrated with robotics so that they could use a joystick to navigate the needle by utilizing a graphical user interface as illustrated here. So now let me give a brief overview of steerable needles and present a bio-inspired steerable needle that was developed in our project. I'll then talk about our shape sensing methods, path following control methods, and our animal experiment with this system. Here we see some of the main steerable needle designs presented in the literature. The first design is based on base manipulation. A flexible needle is inserted into the tissue, and the base of the needle is manipulated to go around the obstacle and reach the target. In this example, the upper black point is the obstacle and the bottom one is the target. Although it is conceptually simple, it can achieve relatively small curvatures and creates large stress on the tissue and becomes ineffective as the insertion depth increases. And the second one is concentric tube or active cannulas. These are pre-curved tubes, and as they are inserted into the tissue one after another, obstacles could be avoided by creating a curvilinear path. However, since they are pre-curved, they do not offer much room to update the pre-planned path. Another way to steer in the tissue is to have a bevel-tip needle, as seen in this figure and the video. So if the needle material is soft and if it is inserted into the tissue, the needle steers thanks to the interaction between the bevel tip and the tissue. To change the bevel tip, to change the bending plane, the needle needs to be rotated axially. These are easy to manufacture, and the range of curvatures could be achieved by a duty cycle spinning, which is spinning the needle body about the needle axis with a certain duty cycle to achieve desired curvature. However, this dependence on axial rotation creates risk of strain on the tissue, which is not ideal. The needle that was developed and used in our project was based on this bevel tip steering principle, but without this disadvantage. So EDEN 2020's needle was the programmable bevel tip steerable needle, or PBN in short, manufactured with a kind of medical grade polymer. It consists of relatively soft and slender segments, which are held together via this interlocking mechanism. It constrains the relative transverse motion of the segments. Each segment can be driven longitudinally independently. Thus, the needle can steer thanks to the bevel tips. And each segment has two working channels, which could be used for a variety of purposes, such as sensorization and drug delivery. And the steering could be achieved in this way. Here it curves down because of the asymmetric forces at the tip, as seen here. However, if the bottom segment was made the leading segment, it would curve up. So many curvatures could be achieved one after another. Here is a video illustrating the navigation of the needle. As you see, to change the curvature or the bending plane, no axial rotation is required. Therefore, it could be made of more compliant materials, as it doesn't need to transmit the torque from base to tip to rotate it. This needle design is bio-inspired. So if I can open this video. This needle is what was inspired. Sorry, I think I clicked on the wrong button. Why these wasps, which use their these egg-laying channels to lay their eggs into wood, for example, in this case. And they use a similar mechanism as PVNs. However, one of the open challenges in these steerable needle control and navigation in the brain is the real-time localization and shape sensing and tracking. Because of the absence of line of sight in needle insertions, intraoperative medical imaging modalities and proprioceptive tracking methods such as electromagnetic and optical fiber-based methods are preferred. Among these methods, the advantages of optical fibers being non-ferromagnetic, flexible, and small in size make them a promising technology for needle localization. Tip tracking or shape sensing based on fiber Bragg gratings, FPGs in short, is one of the methods using optical fibers. And this method is what we use in the project. I'm not going into the details of FPG theory. However, if we have a multi-core fiber and discrete FPG sets along it, as seen here in these two illustrations, the strain corresponding to each FPG at the cross-section and therefore the curvature vectors corresponding to those cross-sections could be estimated. Then this discrete curvature information is interpolated and the shape is reconstructed from bottom to the tip. Here are the methods used to reconstruct the shape. The first three shown here are the ones requiring interpolating the discrete measurement data and are based on constructing parallel transport frames and Fernet-Serret frames and circle arcs for the piecewise constant curvature method. The fourth method is based on fitting a polynomial to the discrete curvature values, which are then double integrated to have the shape. So here the intermediate curvature values are obtained via the continuous polynomial, which is an alternative to the interpolation. The last method in the literature is the data-driven regression approach, which is a sensor model independent approach and only requires the raw data of the FPG wavelengths to estimate the tip position. In the first four methods, although the interpolating the discrete data and curve fitting helps estimating the shape. The inherent approximation accuracies occur because of the interpolation method, which I will touch on later on in my presentation. So we conducted two shape sensing studies. In our first study, we used linear interpolation here for the interpolation method, and then reconstructed the shape using parallel transport frame-based method. However, in our second study, we investigated the inherent approximation inaccuracies of the methods that are used to estimate the intermediate data and proposed a method to completely eliminate this step. So let me start with our study where we used interpolation and then continue with the other one. So here, as I said, we applied linear interpolation. These are the devices required for FPG-based sensing. The fibers were inserted into one of the working channels of each segment. The other working channel was used for electromagnetic sensors because they were used as ground truth. The catheter was moved in the air by manually pushing on it from different directions, and tip position and orientation were reconstructed as seen here alongside the ground truth. By the way, don't hesitate to jump in, and if you have any question, ask. In addition, we conducted gelatin experiments where we used a benchtop robotized system to insert the needle into a gelatin phantom that mimics soft brain tissue. Single band and double band experiments were made. The tip pose was used for validation since the reconstruction error is the largest there due to the accumulation of error over the length. The results from all experiments showed that the mean error in position was less than 4.7 millimeters and the mean error in orientation was less than 6.5 degrees. Although our errors could be acceptable depending on the tumor size, we believe that they could be reduced, and the main error source was the inherent approximation inaccuracies, as I said, brought along by the use of interpolation, which we addressed in our next study. So we conducted a quick computer simulation to investigate the performance of the methods requiring estimation of the curvature vectors in between the FPG measurement locations. Here there are three shapes representing three multicore fibers. They are of the same length. However, their inflection points are at different locations, as seen here. Each shape is divided into two parts by its inflection point. Second, the radiuses of curvatures are given. The second parts lie in planes perpendicular to the first parts. The first parts of the shapes mostly overlap, as you see, until the inflection points. The markers on the lines represent the locations of the FPG sets. If you look at the region that includes the inflection points, the curvature vectors here in between the FPGs are estimated via interpolation, just like almost everywhere along the fibers. The cubic spline method was used in this study because for the interpolation, because it was recommended in the literature to have the best results. Now, when we look at the tip position errors in the shape reconstruction using the interpolated data sets, we see there is a significant difference. This shows that using interpolation does not work nicely with all shapes. So we can say that the shape reconstruction accuracy is a function of the position of the sensors with respect to the discontinuities. Therefore, in our following study, to eliminate the interpolation step, we proposed that all the curvature information is collected by the tip FPG set during the navigation, as seen in this figure. This is based on follow the leader assumption. We see the illustration of a bevel tip steerable needle with a multi-core fiber steering in soft tissue in 3 consecutive time steps. We define these curve points, which are not fixed to the needle. Instead, they are fixed to the soft tissue. As the needle advances into the tissue, new curve points are created. The curvature information about these newly created points is collected by the tip FPG set. which is shown in gray here, and the length of it is L. So there might be other FPGs in other parts of the fiber, but they are not used at this stage. As a result, as you see, without a need for interpolation or curve fitting, all the curvature information could be collected by using only one FPG set at the tip. This approach also removes the limit that the reconstruction length can only be so long as the length of it is as the length of the sensorized region. However, as I said, this is based on follow the leader assumption, which might not always be valid. Therefore, to address these, we also introduced a Kalman filter to fuse sensory information obtained at different time steps, either by the same FPG set or a different one. The process model in the Kalman filter addresses the tissue movements, which cause a possible non-zero error in the follow the leader assumption. In the case where more than one FPG set is present along the fiber, the Kalman filter is used to fuse the sensory information of a curve point from different FPG sets. For example, for one of these curve points, the curvature information was obtained when this FPG set passed by it. And then when this FPG set arrives that point, it's going to take another measurement. So these two information are going to be fused with the Kalman filter. But of course, the process noise covariance matrix will apply on the measurement of the first measurement, and the measurement noise covariance matrix is gonna be accounted for in the second one. So if you remember the simulation results in the previous slide, I added the results obtained using this method to the same table. Just to emphasize, all the simulations are noise-free simulations, and this method simulation was conducted with only one FPG set at the fiber tip. As you see, the error was decreased significantly. These are the simulation parameters. We validated this reconstruction method with gelatin phantom and sheep brains. Electromagnetic sensors were used as ground truth. All the insertions were carried out to a depth of 120 millimeters, longer than the sensorized length of the fibers, thanks to the proposed sensing method. And here the results were compared with the method requiring interpolation. So in vitro experiments are the ones we use gelatin, and ex vivo experiments correspond to the brain tissue experiments, and single band shape and double band and 3D shape experiments. So first column represents the interpolation-based method, and the second column is the proposed method. So in comparison to the interpolation-based method, similar results were obtained in the case of the single band shape. However, especially when looking at the maximum error values, which are the yellow ones here, the performance of the proposed approach outperformed the interpolation-based approach, especially in the case of experiments with 3D shape and double bands, for which inflection points were shown to be one of the most significant error sources for the reconstruction methods requiring interpolation. This sensing method was also used in our animal experiment. Here we used Eden 2020 project's system. This is the overall photo, including the components as in the slide I showed you earlier. This represents the patient's head, or in our animal experiment, it was the sheep's head. And the surgeon uses a haptic joystick shown here to guide the needle. The head was drilled using a drilling tool as seen here, and the PVN was inserted as shown. The alive animal assessment of this platform aimed to establish the effectiveness of the surgical workflow for keyhole neurosurgery, the feasibility and safety of PVN delivery, and 5-day implantation within the brain. Implantation is necessary because from time to time chemotherapy drug needs to be injected depending on how good the tumor's response is to the treatment. So in the alive animal experiment, the needle was inserted and left in the brain for 5 days. The part of the needle that was outside of the brain was cut flash, as seen here, and then closed as in this figure. Of course, the optical fibers were pulled out before cutting the needle to save them for other experiments, and they were not needed anymore after the needle reached the target. Clinical data was recorded for 5 days, and no abnormal or out of normal parameters were noted throughout the observation period. We also investigated the autonomous path following navigation of programmable bevel-tip steerable needles in the brain. So this is the block diagram of the control algorithm we proposed. So the reference path is given, HLC is short for high-level control, and NLGL is nonlinear guidance law, which we borrowed from path-following controllers of fixed-wing aerial vehicles. They also have similar non-holonomic constraints, as I mentioned briefly in the introduction. The nonlinear guidance law is illustrated here. This is the reference path and that the needle is supposed to converge on. And this is our needle. The tip position of the needle is known thanks to the FPG-based sensing. In this method, a pseudo-target point is determined on the path for the needle to aim at each time step. It is always calculated as the intersection point here, therefore guarantees smooth convergence. And the desired curvature is generated here for the LLC, low-level control. Low-level control approach that require good mathematical models for robot tissue interaction are not generally preferred because, for example, if we take the example of neurosurgery, needle tissue interaction in the brain is highly unpredictable because of several anatomical reasons, such as tissue heterogeneity, boundaries of tissue layers, bleeding. All of these lead to difficulties in constructing an accurate mathematical model. Therefore, the active disturbance rejection controller, ADRC, was chosen as it is known for its parameters having a wide adaptive range and its robustness even in the presence of a rough mathematical model. And it was used alongside the simple linear needle tissue interaction model. The output of the ADRC is mapped to needle segment offsets via sequential quadratic programming or SQP, as there may exist more than one catheter tip configuration to achieve the commanded curvature. Then the needle tip is programmed and it is driven into the tissue for a certain length. So when arranging tip configuration, the navigation stops to prevent overshoot in the case of discontinuities, which was one of the contributions of this study. Then the loop is closed with the FPG-based sensing. We validated the methods with experiments as seen here. The controller parameters were optimized with simulations. This is the illustration of the experiments. The PBN was guided along a curvilinear 3D path, which avoids virtual obstacles. We also conducted target hitting experiments where a virtual target moved linear trajectory after the needle started autonomous navigation toward the target. This is actually a realistic scenario because the tissue is soft and during needle insertion, the tissue might move, for example, by several millimeters. As a result, the insertion paths and target motions from these experiments show that our algorithm guided the needle effectively towards the moving targets. From one of the path following experiments, the reference and measured paths are shown in these figures. They show that the control law was able to track the reference path. So this slide completes the first part of my presentation, where I covered our methods for steerable needle localization and control from my PhD. Now I will continue with continuum robots used in cardiac interventions. This is a project conducted in DuPont lab, led by my postdoc supervisor, Professor Pierre DuPont, and aims to investigate the transcatheter robotics-based approach for mitral valve repair in the beating heart, as well as achieving improved imaging. Let me begin by motivating the problem a little. Cardiovascular disease is the leading cause of death, killing over 17 to 20 million people on an annual basis. In fact, I was very surprised when I heard this. The number of deaths from this disease, including heart valve disease or arrhythmias, exceeds those from all types of cancers combined. Recently, the use of minimally invasive routes to diseased regions in the heart or vascular structures are attempted with increased frequency due to the advantages I mentioned earlier. So the mitral valve is located between the left chambers of the heart, as seen here. The blood comes from the lungs to this chamber, which is the left atrium, and then it goes down to the left ventricle through this mitral valve, and then to be pumped to the body through the aorta. Normally, this mitral valve needs to seal very well when the left ventricle contracts, so that all the blood goes through the aorta. However, in some people, this is not the case. The mitral valve gets leaky and mitral regurgitation occurs, which is, as you see here, the blood leaks to the upper chamber instead of going through the aorta. This affects the blood circulation and can even cause death. It can be very serious. To deliver valve repair devices to the diseased valve through an intracatheter method, the clinician usually goes up the femoral vein and reaches the heart, as you will see now, and through the septum, they try to orient their catheter orthogonal to the diseased valve here. Currently, all valve repairs are done using manual catheters. The goal of this slide is to give you an idea of how difficult these procedures are. One of the home runs of transcatheter valve repair is the mitral clip, as you see here, and it is used to clip together the two leaflets of the mitral valve in order to stop the valve from leaking. It looks easy from the animation shown here, but look at how the shape and position of the catheter are controlled. It involves rotating knobs, rotating segments of the catheter, translating segments of the catheter, as well as sliding the entire catheter handle set back and forth on a plastic sheet. And given that it is this complex to use, and this is a procedure conducted in the beating heart, which means there is a very little room for a mistake. It requires most cardiologists to conduct a few hundred procedures a year to become and stay good at it. So robotics might be able to help with this. Now let me look at the imaging used to guide the catheter. The two main imaging modalities used in these procedures are fluoroscopy and ultrasound. Fluoroscopy shows you the catheter, and when you are using contrast agents, the vasculature. It's mainly used for navigating the catheter to reach the mitral valve. For deploying the device on the valve, 2D and 3D ultrasound are used. These show you both the tissue and the device, but inferring device tissue contact is challenging. The key part about this procedure is, there are three of them. The device needs to grasp both leaflets at once. And secondly, the device needs to be positioned at the correct location on the valve with respect to the leak. And lastly, a sufficient amount of each leaflet needs to be grasped on each side of the clip. As you can see from the videos, knowing whether or not you have accomplished these goals based on the imaging requires a lot of experience. So first of all, to improve imaging, an endoscopic tip was proposed in the scope of this project. As you see here, the camera is embedded in a clear silicone tip because when the catheter tip is inside the beating heart but not touching tissue, all you can see is the red blood that is contacting the tip. If the camera touches the tissue, then there is no line of sight and you again don't see anything. But now, since there is this clear silicone interface when you make contact, as shown here, the blood is displaced from the silicone interface between the catheter tip and the tissue, and you get a high-resolution view of the contact region. However, the access here was through the apex, which means it was needed to go through the heart wall. The transcatheter access from the groin is preferred over the apex. Therefore, this is what we have been investigating. We conducted a design study to optimize the continuum robot parameters for the mitral valve repair procedure, developed an actuation unit, and conducted a modeling study, which I will now present. To achieve intrinsic steerability in long catheter devices, traditionally two approaches have been proposed. Concentric tube robots, as in the case of steerable needles. However, it is now not surrounded by tissue, as you see, so it can move freely, for example, in the cavities of the heart. And using translation and rotation of individual tubes, the distal tip of the robot can be steered. Now, the other popular approach is tendon-driven serial continuum joints, like the 2-degree of freedom robot you see here. In these robots, one or more tendons are attached to the distal tips of each joint, and actuating these degrees of freedom can be achieved by tensioning the individual tendons. Each approach has its limitations. Concentric tube robots can have snapping instabilities where the tip of the robot can snap from one minimum energy state in its workspace to another, much like an unstable equilibrium of an inverted pendulum. While tendon-driven robots have a limited number of degrees of freedom. However, transcatheter applications need more than 3 degrees of freedom to traverse the tortuous route through the septal wall to the heart valve. The septal wall is shown here. It is the tissue between the right and left parts of the heart. To address these limitations, many transcatheter devices already apply a combination of the two approaches that I discussed on the last slide, namely a set of tendon-actuated tubes that are telescoped within one another. The mitral clip seen here is a great example. Here we can see 3 telescoping sections, an outer sheet across the septum, an inner sheet that bends and orients with respect to the mitral valve, and an innermost section that holds the mitral clip device and rotates it with respect to the valve, so that this makes up 8 degrees of freedom. However, when such a set of telescoping tubes are actuated, they exhibit the kind of twisting observed in concentric tube robots, which was not modeled in the tendon-driven robot literature. You can see the amount of twisting observed for a 2-tube example here on this slide. When the tendons are aligned at 90 degrees with respect to each other and actuated, The shape of the robot displays a significant amount of twist in addition to bending. Therefore, the objective of this work was to generate a complete mathematical model for tube bending and twisting for concentric tube tendon-actuated robots. For our model, we made use of the Coursera rod theory, which is widely used to model continuum robots. Let's examine the case of a single tendon-driven catheter. I'm skipping some of the math here. However, these equilibrium equations determine the spatial evolution of the internal forces and moments, and therefore, through this constitutive model, the rod's center line and orientation. We solve this problem as a two-point boundary value problem. What we know is the magnitude of the tendon force at the tip and the position and material orientation of the base of the robot. We employ a shooting method to solve this problem. The challenge for us, however, was that we wanted to model multiple telescoping tubes, and this model was limited to a single tube. Now for two tubes, the situation is very similar. However, note the tubes are not exactly independent in every way. They share a center line until the tip of tube 1. This means until this point, the bending curvature and shear strains in the catheter cross sections are exactly the same for both tubes. Meanwhile, since the tubes are allowed to twist and elongate with respect to each other, twist and elongation strains are independent. This gives us 4 common equations for every cross section and 4 independent ones, resulting in 8 equations with 8 unknowns. These equilibrium equations can now be solved again exactly like that for the one tube case. This figure illustrates the output of our computer simulation. The red is a single tube and the blue-green pair is 2 nested tubes. As seen here in these cross sections, tendons are 90 degrees apart from each other. In 2-tube case, each tube has only 1 tendon. This shows the case where only the first tendons were tensioned. We do not see the red single tube here because it perfectly overlaps with the 2-tube case. This case is similar, where only the second tendons were actuated. So these cases show that when the individual tendons are actuated, our model matches previous work exactly, because there is no twist when only the tendon of one of the nested tubes is actuated. However, then in the middle, both tendons were tensioned. As you see, there was a discrepancy because twist occurred and our model took it into account. And in the single tube case, there was no twist. Here in the graph, the single tube doesn't show any twist as expected. However, these theta values show the twist angles of the 2 tubes, and you see how they twisted. Then we conducted experimental trials with varying tendon forces, inner catheter lengths, and angles between the inner and outer tube tendons. Overall, our mean error was 3.7% of the total steerable length of the catheters, which was very comparable to previous literature. Our following study included our first steps in algorithmic catheter design and robotic catheter control for the specific procedure of transcatheter mitral chordae replacement, which is one of the treatments addressing mitral valve regurgitation. Chordae tendineae are tough, fibrous cords shown here in white that connect the papillary muscles to the valves of the heart. Chordae replacement refers to a surgical procedure in which damaged or ruptured chordae are replaced with synthetic materials or donor tissues to restore the proper functioning of the heart valves. The workspace for this procedure requires the catheter tip to and the papillary muscles. Using a 3D in silico model of the heart, we first employ a piecewise constant curvature catheter model to determine the number of curved segments, minimum radii of curvature, and maximum bend angle of each segment to produce the desired reachable workspace. We then built a robotic drive system and used an existing set of catheter sheets to demonstrate the capabilities of the design approach by navigating to a set of points on the mitral valve and the papillary muscles inside a 3D printed version of the heart model. Each sheet is connected to these cartridges, and this is the flipped version of the cartridge, and they are attached to these carts, and the carts is seen here. The power transmission, you see the matching gears between the cartridge and the cart. This power transmission is needed for tandem tensioning. The motors are connected to the carts, not the cartridges, and only the cartridges are sterilized, which doesn't include any electronic equipment. The carts are moved longitudinally with respect to each other thanks to the lead screw motor pairs. Using keyboard commands, the robot was navigated to each target point with endoscopic image used to confirm that each point could be reached successfully. These are preliminary results, and this is an ongoing work, and future work will incorporate path planning in catheter design and teleoperated catheter control. In summary, we have discussed the benefits of minimally invasive robotic surgery compared to open and manual surgery. It offers improved patient outcomes and quicker recovery times. Additionally, we explored two promising continuum robots, specifically steerable needles and tendon-actuated concentric tube robots, which show great potential for enhancing surgical procedures. Furthermore, we acknowledge that introducing autonomy in surgical robots poses challenges, however, can be minimized by advancing shape sensing, modeling, and control approach, which we covered all of them here. Looking ahead, in my opinion, future work in this field will probably focus on increasing autonomy in robotic surgery, as well as exploring new materials and production methods to create smaller robots that can further improve the outcome. So in conclusion, the advancements in minimally invasive robotic surgery, coupled with continuum robots and the key technologies I presented, hold tremendous promise for the future of surgical procedures. And of course, I would like to thank my supervisors, lab mates, and colleagues, and thank you for your attention and interest, and I would be glad to answer your questions.